complication called Peripartum Cardiomyopathy. Dr. Kanchan Sharma is a laparoscopic orthoscopic ARP specialist. She is the national chairperson of the NCD Committee FOXY, director and chief consultant of IVF Center in Kanpur. And she's going to talk to us on this not so common cardiac condition. Thank you, madam.
Thank you, Chairperson. First of all, my greetings and congratulations to Bangalore Society for having such a wonderful conference. Being a NCD chairperson, this is my pleasure to have such a topic on peripartum cardiomyopathy, because now this is a rare disease, and any patient coming with the dyspnea, with all these problems in the last trimester, in the last 1 month and the 5 months after delivery, we should think about the peripartum cardiomyopathy. So, directly coming with the case scenario. This is the case scenario. Mrs. X, she is 38 years and para 3 with history of hypertension and obesity, presenting for the shortness of the breath and cough and lower extremity edema, and vaginal delivery of the twins at 36 weeks of gestation. She had history, pregnancy complicated by preeclampsia, and her vitals were blood pressure 132/92, heart rate 110 per minute, oxygen saturation was 99% on 2 liter. On examination, her JVP was raised and bilateral basal crepitations were there, and 2+ splitting edema was there up to the knee bilaterally. And that patient presented with the lab findings BLP 1498, while the normal value are less than 125 picogram per ml, and drop 824 nanogram. And the normal value for high sensitivity cardiotropin below 14 nanogram per liter. Creatinine is 1 and hemoglobin is 10. Chest X-ray shows enlarged cardiac cleft and bilateral pleural effusions. So this type of patient can come to you at any time. You do her ECG and shows findings. ECG shows tachycardia. And now what is your diagnosis and what are the differentials? These type of the cases may, although they are rare, but they may present to all of us, and we have to keep a diagnosis of peripartum cardiomyopathy, and we have to think on these outlines. We should know about the normal cardiovascular changes in pregnancy, definition of PPCM, what is epidemiology, what is the etiology, and what are the diagnostic point, and how these type of patients they present, and how will you manage these type of patients, and you have to say about the how this has present later on. What is its prognosis? So coming on the normal physiological changes in the pregnancy, as we see in the different trimester, the first trimester heart rate normally that increases, in the second trimester again by 10 to 15%, in the third trimester it increases by 15 to 20%, and in labor again it increases, and after delivery it reduces to normal. In the same way, stroke volume that again increases in both the trimester, and the third trimester it comes 20 to 30% down, and again increases during the labor and delivery and come down in the postpartum period. The same is with the cardiac output, systolic blood pressure, diastolic, and the systemic vascular resistance. I am not going into detail because of the less time. Now coming on the normal presenting features, that normal cardiac findings, there may be raised GBP with prominent pulsation even during the normal pregnant ladies. The brisk and diffuse apical impulse may be shifted lateral and upward, loud S1 and S2 with a widely split. Occasional S3 may be there, aorta and the pulmonary flow murmur may be there, and memory circle edema may be there. That may be a normal. You have to differentiate. What are the abnormal findings? Abnormal findings are progressive dyspnea, the chest pain, hemoptysis, syncope, cyanosis, clubbing. There may be systolic murmur grade 3 and above, and there may be persistent neck pain distension, diastolic murmur, and there may be persistent arrhythmia and persistent split S2. So, coming on the peripartum cardiomyopathy definition. What is the definition? There may be all 4 of the following: heart failure within the last month of the pregnancy and 5 months postpartum, absence of the prior heart disease, no determinating cause should be there, strict echocardiography, indication of the left ventricular dysfunction. Ejection fraction in these cases are usually less than 45%. Fractional shortening and diastolic dimension more than 2.7 centimeter per meter square. So coming on the incidence, it is said that this is although a rare disease, but 1 in 4,000 live birth was found in United States, and it is increasing now. Incidence is increasing with age, so we are discussing it here. And incidence also increases with the age. This has a genetic predisposition. It is said that it is linked to TTN variant and more in black women rather than the white women. Research has been done that cathepsin D that is collected into 16 kDa fragment, which causes endothelial apoptosis, capillary dropout, and vasoconstriction. So therefore, this is responsible for BPCM. Placental angiogenic factors, as we have seen that this is associated with hypertensive disease of the pregnancy. During the late gestation, placenta secretes soluble FMS like tyrosine kinase 1 and anti-angiogenic protein, and it sequesters vascular endothelial growth factors (VEGF) and the placental growth factors, thought to be the major driver of hypertensive heart diseases, and the endothelial dysfunction in preeclampsia has also been found to be associated with PPCM. There are certain risk factors. Probable risk factors are twin pregnancy, as we have seen in this particular case. There is a twin, so there are more chances. High parity, high gravity, extremes of reproductive age, prolonged tocolysis. If you have given, if your patient is suffering with preeclampsia, has a genetic predisposition, as I have already discussed, is obese, has a African ancestry, has a cocaine abuse, is malnourished, is hypertensive, is a smoker, then there are more chances. And if etiology poorly mechanism is defined usually, and some proposed etiological factors are viral myocarditis. If patient is having parvovirus or human herpes virus 6, then there are more chances. Abnormal immune response, abnormal hemodynamic response, prolactin, as I have just told, produce 16 kDa fragment, and apoptosis and inflammation, selenium malnutrition, prolonged tocolysis use, and increased oxidative stress. All these patients may have more incidence. These are two diagrams. In the second diagram, you can see that all the 4 chambers of the heart are enlarged and there is a thinning of the wall. These are the findings of PPCM. So what are the presenting features in this? There may be paroxysmal nocturnal dyspnea, there may be dyspnea on exertion, orthopnea, there may be chest pain, cough and palpitation, and hemoptysis even. And what are the signs? These are the tachycardia, tachypnea, maybe regular or irregular pulse, maybe persistent neck vein distension, maybe blood pressure normal or even decreased apex speed is shifted in these cases, thirsting in nature, maybe S3 and S4 gallop, mitral holocystic murmur may be there, maybe bilateral basal crepitation and hepatomegaly if there is RHF. So we have to see about the differential diagnosis. What are the points from which we have to do differential diagnosis? These are the valvular heart diseases, congenital heart diseases, hypertensive disorders, myocarditis, pulmonary embolism, acute coronary syndromes, and HIV. So diagnosis is confirmed after exclusion of following diseases. We have to exclude anemia, thyroid disease, septicemia, idiopathic dilated cardiomyopathy, accelerated hypertension, myocardial infarction, acute pulmonary embolism, and severe preeclampsia, pulmonary vasculitis, and previous valvular diseases. These are the different points on which basis we can differentiate PPCM with the other diagnosis on the basis of history, biomarker, echocardiography, and additional tests. I am not going in detail because I have less time. These are points which are very good and we have to remember all these points. And this is a flow chart for the points which I have already discussed. When a patient comes, you have to see the sign, symptom of the heart failure, sign, symptom, and then confirm the diagnosis on the diagnostic points which I have already discussed. And investigations, ECG is very good investigation and should be done in all these cases. You have to involve your cardiologist friend and see that there is a sinus tachycardia as is seen, arrhythmia, atrial fibrillation, elevation strain pattern, and there is normal or low voltage QRS complex with the inverted T wave, non-specific ST wave changes are there. There are biventricular and biatrial dilatation and conduction defects which are present. While you do the order for the chest X-ray, which is a very important investigation, you find that cardiac shadow is enlarged in transverse diameter and there is hyperinic lung fields which are present in this, and bilateral pleural effusion even you can find. In echocardiography, you see that reduced LV wall motion is there. There is dilatation of all the four chambers and particularly the left ventricle is dilated. Reduced ejection fraction is a very important finding, that is less than 45%. Biomarkers, as already I have discussed, anti-proBNP is very important, very sensitive biomarker. CRP indicating the prognosis, 16K DA prolactin, interferon gamma, asymmetrical dimethyl arginine, cathepsin D, and FAS-FO1. MRI, if needed, then use of considering only risk and benefit ratio, because in pregnancy we don't advise MRI. So this is a thing which we have to do the multidisciplinary approach. Obstetrician, cardiologist, and anesthetist all have to join hand to treat such a condition. According to management, we have to aim for the treatment. We have to alleviate symptoms. We have to slow the progression of the LV dysfunction and improving the survival. These are our mottos. So, how we will treat? Treat of BPCM, maybe either acute treatment or the chronic treatment. In the acute treatment, your cardiologist friend will give the patient oxygen, diuretic, vasodilators, antiarrhythmic, inotropic agent, mechanical ventricular support, anticoagulant, pentoxifylline, intravenous immunoglobulins, and bromocriptine. And in the chronic treatment, lifestyle modification, diuretics, RAS blocker, beta blocker, anticoagulant, cardiac synchronization therapy, and implantable cardioverters. So, initial evaluation, in any of these patients, when they come to you, you have to do initial evaluation, in which what will you do? First, assess the cardiopulmonary distress and confirm the diagnosis. For cardiopulmonary distress, you do SBP, heart rate, respiratory rate, lactate, and see other things about the oligonucleotide, etc. The confirmed diagnosis, you see the ECG, blood test, and echocardiography even, and lung ultrasound may have to be done in many cases. And if you confirm about the severe PPCM with cardiopulmonary distress or maybe without cardiopulmonary distress.
2 more minutes to go.
In case this is with cardiopulmonary distress, optimizing preload, optimize oxygenation, add inotrope, urgent delivery should be done in these cases, and consider bromocriptine. And recovery may be and by the transplantation and the weaning. In case it is without the cardiopulmonary distress, it may be in antepartum period, may be postpartum period. So you have to give treatment accordingly and consider the delivery if she is pregnant and present to you in antepartum period. So anticoagulant, according to this, pregnancy itself is a hypercoagulative state with decreased body natural coagulant. So consider anticoagulant in these conditions. Warfarin and heparin both are safe even during breast feeding. Assisted devices, these are intra-aortic balloon pump, extracorporeal membrane oxygenation, and many wearable cardioverter defibrillator ICD and CRTs. So drug during breastfeeding should be avoided. These drugs, spironolactone and all, and can be used heparin, warfarin and all the ACE inhibitors and beta blockers. So advice during discharge, daily fluid intake 1 to 1.25 liter, avoid heavy work and aerobic exercises. Permanent contraception is advised, nutritional supplementation, and pay more attention and concern in case of common cold and RTI. If possible, do the light exercises. Breastfeeding now discouraged in these cases. So follow up of the patient, follow up echocardiography at the rest, and test for after 6 months. There are actual less data about the discontinuation. 1 or 2 slides. If patient improves, then after 6 months gradually taper doses of drug up to 12 months. This is the in the subsequent pregnancy, 50% show further deterioration, while 20% amongst the group which has a complete recovery, 20% may relapse even in the next pregnancy. So take home message is now because of changing lifestyle and increasing age of conception, the incidence of peripartum cardiomyopathy is increasing. The need of our is to be vigilant and have multidisciplinary approach. Timely diagnosis and proper management can recover the patient fast. Advise healthy diet, nutrition and appropriate exercise to keep your heart fit. So happy heart, no beauty shines brighter than a healthy, happy heart. Thank you. Be kind to your heart. Be smoke free. Manage stress. Eat healthy. Remain stress free. Do more exercises and more awareness classes. Thank you very much, Chairperson.
Thank you, madam, for that exhaustive and excellent lecture which you have given us. You really expounded so clearly to us the management of such a rare cardiac disease, but which could lead to severe mortality in the mother. Earlier, the mortality was very high. Now with advancement in treatment and diagnostic modalities, the mortality has come down. You have very clearly told us what is the criterion for diagnosing this condition, that there should be no pre-existing heart disease, because many people confuse it. If a cardiac patient with failure comes, they diagnose it as